Fine. The last speaker for this session is Regina Vitriolo, who works as a gynecologist in the Philippines. She has special interest in gynecologic ultrasound and ultrasound-guided gynecologic intervention procedures. She is the president of the Philippine Society of Gynecology and Intervention Ultrasound. She also has extensive experience with pelvic tuberculosis, and incidentally, that's a topic that she will be addressing this evening. Welcome to you, Dr. Vitriolo.
Good day, everyone. First of all, I would like to thank Professor Tomboy again for the invitation. It is always a pleasure to be part of this issue of ultrasound essentials. I'm Dr. Regina Panlili Vitriolo from the Philippines, and I've been tasked to discuss the features and management of abdominopelvic tuberculosis, a topic that is close to our regions. I have no disclosures. And TB is a very old disease. It's very recalcitrant, and millions of people are still affected every year. And one of the UN Sustainable Developmental Goals envisions a TB-free world in 2030. But TB continues to be a critical clinical and diagnostic challenge. And some of these challenges include the multi-drug resistant tuberculosis and the difficult to diagnose extrapulmonary tuberculosis. The incidence of extrapulmonary tuberculosis is about 15 to 20% globally in non-HIV patients and is doubled in patients harboring HIV. And genital TB, one of the extrapulmonary lesions, is an underdiagnosed presentation affecting both males and females with a profound effect on fertility. And our focus for today is on female genital tract tuberculosis. This is usually a secondary infection from a latent pulmonary TB. There is some evidence that it can be acquired as a primary infection via sexual transmission, but data is limited on this. The entire genital organ can be affected, thus affected individuals present with non-specific signs and symptoms. And the main risk factors leading to female genital tract tuberculosis are influenced by one's geographic location, with close exposure to patients with pulmonary TB, residents and travel to high endemic countries with high-risk regions like Africa and Southeast Asia, where the Philippines is, unfortunately. Individual factors include a previous medical history of TB infection, malnutrition, medical comorbidities, and HIV infection, which has a risk of disease progression of about 8 to 10% of patients who are not on antiretroviral therapy. Female genital tract TB usually affects women in their productive age group, and the most common presentation in developed countries is infertility. And about 40% actually, however, are asymptomatic. They can also present with menstrual irregularities, non-specific abdominal pain, or complaint of chronic pelvic pain. While postmenopausal women are rarely infected, but they can present with symptoms resembling endometrial malignancy, like postmenopausal bleeding, or they can have persistent leukorrhea and findings of biometry. So obviously genital tract tuberculosis can mimic or coexist with other gynecologic and abdominal pathologies, but the most common differential diagnosis and mimics of female genital tract tuberculosis due to similarity of clinical presentation and even with some imaging features include the pelvic inflammatory disease, ovarian cancer, in ovarian carcinomatosis, and endometrial cancer. Often the disease goes undiagnosed or is misdiagnosed and is treated as chronic non-specific pelvic inflammation. And physical examination may not help at all in 50% of cases because they are normal. So we may be able to appreciate abdominal tenderness, adnexal masses, or even ascites, as well as that classic doughy feel of the abdomen in patients affected with genital tract tuberculosis. And we may also observe vaginal discharge, vulvar and cervical ulcerations if this or part of the genital tract are affected. The gold standard for the diagnosis of TB is always the demonstration of the acid-fast bacilli, either through a positive smear or positive culture of appropriate body fluids, particularly for genital tract tuberculosis like vaginal discharge, menstrual blood, or histology with cacheating granuloma on endometrial biopsy or other tissue biopsies. And these are what we call the bacteriologically confirmed genital tract tuberculosis. But in the absence of bacteriological confirmation, a strong clinical evidence consistent with active extrapulmonary tuberculosis is enough to start treatment for these patients. So conventional culture techniques has always been the Lowenstein medium, but usually it takes about 6 weeks to grow the mycobacterium. Recently, this has been replaced by automated liquid culture systems, which have shorter turnaround time and better yield than the LJ medium. And the most preferred liquid culture system is the Mycobacterium Growth Indicator Tube 960, which takes only 2 to 3 weeks to grow the mycobacterium, but negative cultures are reported at the end of the 6th week. But this is still important because the microbiological detection of TB is critical because it allows people to be correctly diagnosed and started at the most effective treatment regimen as early as possible if the cultures are positive. But since TB, genital tract tuberculosis, is a paucibacillary disease, it is very infrequent to be able to demonstrate the acid-fast bacilli or the granuloma, and even difficult to get this tissue sampling. So a combination of tests or the composite reference standards has been suggested by most authors to strengthen the diagnosis of female genital tract tuberculosis, and this includes the newer diagnostic modalities like the polymerase chain reaction, but has been shown to have some high false positive tests, and also the gene expert, and also laparoscopy with probable findings of genital tract tuberculosis, but this has very limited use for this. Imaging modalities are especially useful also in the diagnosis of female genital tract tuberculosis. When there is suspicion of possible genital tract TB, a chest X-ray showing a positive pulmonary TB may increase the suspicion for the diagnosis, while CT scan, MRI, and PET scans can better detect tubo-ovarian masses and help differentiate between TB and ovarian cancer, but these are very expensive imaging modalities. Hysterosalpingography are being done for infertile patients, and they are useful for detecting the uterine and tubal diseases, but this has to be avoided or be careful because it can activate or flare up active tuberculosis. Ultrasound, which is the more readily available and affordable imaging modality, probably in our regions, allows us to evaluate the ovarian, the uterine, extrapelvic involvement, but then familiarity with the sonographic features associated with genital tract tuberculosis is important. So let's go through this. So the fallopian tubes, again, are almost always infected, 100% bilateral, either through hematogenous route, and patients may present with the PID-like symptoms or sometimes are asymptomatic. And on ultrasound, there can be just normal sonographic features early in the disease in 40% of cases, but later on we may be able to see the thickening of the fallopian tubes, eventually the PID sonographic features, spectrum of hydrosalpinx, pyosalpinx, tubo-ovarian complex, and tubo-ovarian abscesses. Here we can see the typical pyosalpinges, but this is associated with genital tract tuberculosis. We have the Cogwell sign of the pyosalpinx, but this patient presented with a 2-month history already of a hypogastриc mass. And the tubal walls are also thickened with chronicity of the infection, and they may present as just complex adnexal masses. As I mentioned, the infection is commonly bilateral. It tends to affect the abdominal rather than the uterine ends of the tubes. And the ampullary region of the fallopian tube would show the earliest changes, and the fibrae are swollen later. They may also appear as multilocular masses. We have to be careful and try to look for the ovaries. But in female genital tract tuberculosis, the entire genital tract should be assessed, including the surrounding abdominal pelvic cavity, because they present with a spectrum of sonographic features. These are bilateral solid masses, but these are also fallopian tubes that have cacheation necrosis in advanced female genital tract tuberculosis. And on Doppler, you see it's a vascular because of the cacheation necrosis. If HSG is done, it shows the terminal sacculation and occlusion of both fallopian tubes, causing the hydrosalpinx or even pyosalpinx with recognizable fimbriated end, giving us this tobacco pouch appearance, which is a classic imaging sign seen on hysterosalpingogram in 20 to 50% of cases of genital tract tuberculosis. And sometimes we may be able to see this on ultrasound. In later stages, the adhesions may occur between the ovaries and the adjacent pelvic organs, resulting in adnexal masses, complex adnexal masses. But we try to look for the ovaries because they are not that affected in 20 to 30% only of cases. Sometimes there can be associated calcification. If left untreated, the infection now spreads to the peritoneum, but most of the time it enters the uterine cavity to give rise to the TB endometritis. And usually this is a focal infection early in the disease, or again, a normal appearance early in the disease, just like in this case, but we may be able to do the biopsies and show the granuloma. In advanced state, there's ulceration, cacheation necrosis, and fibrosis, and patients present with menstrual irregularities as well as pelvic pain and vaginal discharge, again, non-specific symptoms. With extensive destruction of the mucosa and the cycle of cacheation, shedding, repair, ultrasound will show an irregular ragged outline eventually here, a very irregular outline because of fibrosis, which eventually would give rise to Asherman's syndrome. And this is the classic image of the moth-eaten endometrium that I find pathognomonic for TB and endometritis. With extensive destruction of the endomyometrial region, sometimes it's very difficult already to delineate the myometrium from the endometrium, such as in this case, we have a mosaic pattern, and myometrial involvement is very rare. And this is the same patient actually that presented with the solid adnexal masses. This is obviously an advanced genital tract tuberculosis. And if patients are explored, this is what we see, but we really do explore our patients, showing the pictures of the classic tortuosity of the fallopian tube with the recognizable fimbriated end, as well as the studding of the entire uterus by the millet seed-like tubercles on the uterine surface. So we always have to look at the entire spectrum of the patient on ultrasound, but we consider female genital tract tuberculosis, particularly if there is no response to the regular antibiotic treatment for PID, or patient presents with a chronic pelvic inflammatory disease, undetermined infertility, or persistent menstrual irregularity, persistent vaginal discharge, and all workups have been done, including exclusion of genital neoplasms. And I also have to mention that we should consider the in children with PID symptoms with no coitus yet, female genital tract tuberculosis should be considered, particularly if they come from endemic regions. And one of the other infection that increases the suspicion for female genital tract tuberculosis is the infection of the peritoneum in what we call the TB peritonitis. And usually, again, this is a retrograde infection from the fallopian tubes into the peritoneal cavity. And patients present with the classic symptoms of TB, like fever, weight loss, even night sweats, and also diarrhea and constipation. And on physical examination, usually they have ascites, tenderness, and these are the patients that usually present with dewy abdomen. We have three forms. We have the wet ascitic TB peritonitis, wherein there's free ascites with fibrin formation, sometimes may be mistaken for an ovarian mass, benign ovarian mass, but try to look for the ovaries here, and you can see actually the fallopian tube. It can be a loculated ascites, again, can be mistaken for an ovarian mass. There is very particular ascites with calcifications, which are actually attempts at healing. Again, we have to do a transvaginal and transabdominal approach. With extensive adhesions, we have the fibrotic fixed or dry adhesive form of TB peritonitis. There's matting of bowel loops, palisading of bowel loops, outlining of the bowel serosa, as well as mental thickening. And here is a classic example of a female genital tract tuberculosis showing the moth-eaten pattern of the endometrium, as well as the thickening of the uterine serosa, as well, and the peritoneal surface of the abdominopelvic cavity. In TB peritonitis, we have ascites and fibrin formation, and this is what I call as the pelvic blanket sign. And again, if patients are explored, we can see the millet seed-like tubercles studying the entire bowel surfaces as well as the pelvic regions. This was a patient who was actually explored for possible ovarian carcinoma, but turned out to be an extensive abdominopelvic tuberculosis infection. Sharma, in their prospective cross-sectional study of 175 infertile patients, also observed these findings on ultrasound. There can be a PID mass-like features on ultrasound. Endometrium may be normal, and there are conditions also peritoneal or mental thickening associated with TB peritonitis. The treatment for female genital tract tuberculosis is primarily medical, with a standard treatment of 6 months, intensive phase of 2 months, of 4 antibiotics, followed by 3 months of 4 antibiotics. In our country, we usually treat for a year because of relapses. If there's isoniazid resistance, 6-month therapy to include levofloxacin is being given. And more recently, for multi-drug resistant TB, a new oral 6-month therapy known as PPAN has already been started and has a shorter duration from the 18 months previously for drug-resistant TB, and a high efficacy and this has reported high efficacy and is a promising regimen for drug-resistant tuberculosis. There are no specific recommendations regarding treatment monitoring, but treatment response is often based on clinical and laboratory assessment. And patients usually within 2 weeks on drug therapy have a better well-being. Again, we have to clinically correct. Currently, clinical application of surgical treatment is limited, except in patients with a persistent pelvic mass or unknown diagnosis, probably ovarian cancer. However, the consequent complications make surgical treatment of TB patients risky and difficult. So we can have poor visualization, excessive bleeding, bladder and bowel injury, as we might actually incite peritonitis. So the take-home message is TB is a very difficult, also still a diagnostic challenge, particularly for extrapulmonary tuberculosis and genital tract tuberculosis, which is an unrecognized disease. But we always have to do our exhaustive history taking, comprehensive physical examination, appropriate tuberculosis test, do our imaging modalities, but be familiar with genital tract tuberculosis features. But above all, the most important tool for the diagnosis of female genital tract tuberculosis is a high index of suspicion for us to be able to attain that UN goal of ending TB by 2020. Thank you.
Yeah, thank you, Regina, for such a brilliant lecture. I must confess that that's a very difficult topic, obviously, because you are dealing with a condition with very non-specific clinical features. All the features that you talked about, you could have them in chronic PID, which tuberculosis is also a part of anyway. Could also have them in so many other pelvic conditions. So I can imagine how difficult it will be to make a diagnosis. But one of the important things that we also take home is a high index of suspicion. And I'm sure that's why you're making this diagnosis, that you should always have it at the back of your mind in regions that are at risk for tuberculosis, that these women may come out with genital tract tuberculosis. So thank you very much for this. There are presently no questions from the audience now, but let me just ask, could there be any role for laparoscopic surgery here?
For genital tract tuberculosis, actually we try to avoid surgery as much as possible. But then if the diagnosis is not confirmed and we are considering other entities, then there can still be room for surgery, either laparoscopically or open laparotomy. But we do avoid this unless it's really, if all tests show it does not lean towards genital tract tuberculosis or abdominopelvic tuberculosis, then patients are explored.
Yeah. So just like the immediate past lecture, we had the ultrasound guided therapeutic procedure. So with the abscess, you have an abscess. So what would you do?
But then the abscesses, usually with this genital tract TBs, appear as complex masses, and they are not that big as the classic PID pyosalpinges. And it might be difficult to do any drainage or minimal intervention through drainage. So, and these patients actually are asymptomatic. That's why sometimes the suspicion of a possible genital TB is already there. So after all the workup, most of the time these patients are started on a 2-week trial of medications, and they do respond to this. But if they do not respond, we had one patient who had presented with psoas abscess, but that is an inaccessible site. So this patient had to be explored. We cannot do any drainage. But we have not done any drainage for genital tract TB.
Can I just ask, because I always thought that, I mean, it's not something we see, well, in London necessarily very much of, but I always thought the fluid, if you like, the ascites had a lot of septations in it, quite often incomplete septations. Is that right? Is that a very specific, when you see it, it's always TB kind of feature, or is that a bit of a myth? Do you know what I'm talking about?
Not really, but then sometimes what we see that it increases the suspicion for TB is that thickening, that smooth thickening of the uterine serosa and the pelvic peritoneum, and then the fibrin formation with normal ovaries. We might see the pyosalpinges or adnexal masses, but if we see the ovaries or some calcifications and the patients are asymptomatic, that increases the possible diagnosis of genital TB.
There's a question here in the chat saying, we were talking before about abscesses where Joseph was saying, well, you know, they're not well, but you're saying that a lot of these patients with TB, the question is, do they have fever, weight loss? Because we've always been saying we don't treat scans, we treat people. So what are the features, you know, particularly about patients with TB? And Aiga was kind of commenting that it looks like a lot of other stuff. So what are the key things that you might be able to pick out about having this TB that other conditions don't necessarily have?
They do have these PID features on ultrasound, but they are asymptomatic. Most patients are asymptomatic. The question with regards to being systemically unwell occurs when these patients have infected, if they already have TB peritonitis or advanced diseases, but not that they do not really present with the classic pulmonary TB symptoms. They do not. They come in for chronic pelvic pain, and when they have the TB peritonitis, as I've been mentioning in my lectures before, they have this pathognomonic doughy feel of the abdomen. When you press on the abdomen, it seems to bounce back. There seems to be like guarding, but there's no tenderness.
Just out of interest, I mean, what's in younger women who following TB in this way, how many of them have fertility issues due to Ashman syndrome, due to other adhesions or tubal problems? Do they recover, or do you find a lot they have major issues?
Yeah, they do recovery, but they do recover. But then, with regards to it, infertility actually is not their chief complaint. They do recover, but for this we have young patients. But unfortunately, I think we have not followed up with regards to fertility. After medical treatment, they do improve. These masses, the ascites, these complex masses eventually resolve, but there are some that will persist about 40 to 50%, and you can still see thickening of the tubes. But clearly, you can now see the ovaries if they had presented with complex adnexal masses previously. But what is very obvious with them, when you start treatment, in 2 weeks' time, they always complain of a big pelvic pain, a disturbing pain. But in 2 weeks' time, they feel very well. Everything is so improved. So you know that you are dealing already with genital tract TB. That's why some patients are being treated empirically if we cannot really retrieve any biological confirmation.
Yeah, I was going to say that it must be difficult to get a diagnosis sometimes because you don't actually have, you don't retrieve anything. So I guess you just treat them empirically on the basis that it's possible. So it's
Yes.
and it's like a sort of
Right.
test, see if they get any kind of any resolution. Thank you so much. I mean, Aiga, do you have any other queries, questions, or I think we
No,
have
I
to.
think that's all. That's all from my end. I think there's a question on urinary
Yeah.
lamp. I don't think I know what that means.
It's a new I haven't memorized it, but I think it's something to do with fluorescence also. We don't do that in our institution actually. These are some of the newer diagnostic tests, but we don't have in our institution, unfortunately.
Well, can we thank you very much, and thank you for staying on for questions. I think it must be about 1 in the morning.
Yes, it's
Manila.
past one.
So you get the prize for being totally committed, and so I promise that next year we'll put your talk in the earlier in the day, because I obviously clearly did not give that sufficient thought when putting the program together. But thank you for staying up so late and for taking part. We greatly appreciate it.
Thank you also. Thank you so much.
Fine. The last speaker for this